Good morning, everyone. We're going to start the next session, which is on the heritable thoracic aortic diseases and congenital aortic diseases. The first speaker will be Dr. Jennifer Romano, who is at the University of Michigan, Mott's Children's Hospital, and our president of the Society of Thoracic Surgeons. And Dr. Romano will be speaking on pitfalls in adult congenital heart disease for the aortic surgeon. Dr. Romano?
Thank you. I will admit I'm looking forward to a talk that I actually understand. In the past day and a half, aortic surgery has changed dramatically since I trained. So I have no disclosures, and I am not planning on talking about connective tissue disorders or isolated bicuspid aortic valve disease, as that's going to be well covered in other areas. So for background, the adult CHD population is rapidly growing and aging. This is thanks to increasing survival of children going through surgery for their congenital heart defects. And really the challenge is trying to figure out where these patients are best served. And I think where the home is for these patients is institution dependent and probably country dependent as well as to where they can be best cared for. I think in the US in general, these patients are managed by congenital heart surgeons when they have more complex congenital heart disease, such as single ventricle pathology, truncus, double switches, and setting Rastellis, and also when they're younger adults with perhaps fewer comorbidities. And then we see our adult surgeons taking over some of these patients as they age, when they get into their 50s and 60s, take on additional comorbidities and are better managed in an adult hospital. I think what's important is to understand that these patients have unique anatomic and social attributes and really are not just adults. They're in some degree big kids with congenital heart disease. And you have to rethink about the indications for intervention. Quite often what we have for criteria in the adult space cannot just be translated over to these patients simply. And by the time these patients reach adulthood, many of them have already had 6 to 7 sternotomies, so the risks associated with their interventions is not insignificant. Just a brief note in terms of reoperative considerations, peripheral vascular access can be a major issue for CHD patients. Many of these kids who had lines in their infant phase will have either vessel occlusion of their femoral vessels or significant stenoses. And so you really have to think about alternate cannulation strategies. Depending on the type of repair, many of these patients will have had their pulmonary arteries lecompted anterior to the aorta. So in that position, they're sitting directly behind the sternum in the midline and can create challenges with the reentry. Many will also have residual intracardiac shunts, albeit small sometimes at patch margin edges. They still need to be considered, especially with reentry. And tissue integrity is impressive in these patients. You can have a 20 or 30-year-old patient after having had multiple sternotomies, but their tissue integrity is that of a 70 or 80-year-old. Due to the multiple operations that they have, their aorta can be often quite hostile due to multiple cannulation sites as well as prior aortic patches. And many will have conduction abnormalities associated with VSD closures with right bundle branch, which can be of significant concern when you're operating on the left ventricular outflow tract in terms of increased risk of heart block. I'm going to talk about some anatomic subtypes that I think are specific to the aortic surgeon. So specifically the conotruncal defects. These are patients who really have the most prominent issues with dilated aortas, aortic roots, and development of aortic insufficiency. And this category includes our TET patients, truncus, transpose, and double outlet right ventricle. Again, there's specific and unique anatomic and post-surgical considerations for this population. And all these kids are born with dilated ascending aortas at the time of birth that are well above their normal Z-scores because of physiologic flow. And they'll have unique truncal as well as near aortic valve pathology that needs to be considered. And although you guys are all aortic surgeons, if you take them to the ORs, many of them will also have right ventricular outflow tract concerns that need to be taken into consideration in terms of if they have absent pulmonary valves or if they've had conduits that need to be addressed. Specifically for tetralogy of flow, they do have some coronary anomalies that you need to be aware of. In about 5%, they'll have a dual LAD or an LAD coming off the right coronary that can be very prominent on the anterior surface of the heart. Their coronaries tend to have a counterclockwise rotation, so the right coronary can quite often take off very close to the main pulmonary, especially when you're just trying to get between the great vessels for cross clamping. And again, taking into consideration any interventions on their right ventricular outflow tract. And these patients often just have inherent right ventricular dysfunction. The right ventricle just at baseline is not normal, even if they appear to have normal systolic function. The double outlet right ventricle population is really the one that has a wide spectrum and deserves thought. So it can vary anywhere from TET type physiology, where they have dilated ascending aortas and roots, but also have significant issues with their right ventricular outflow tract, Our VSD types may have very complex left ventricular outflow tract baffling procedures that can cause subaortic stenosis as these patients age. And the most complex being the transposition type, or Thoracic being the double outlet right subpulmonary PS patients who have more complex great vessel anatomy with side-by-side great vessels. And this is a population that is at highest risk for aortic dilation as well as progression to neo-aortic regurgitation. In terms of those patients who have undergone an arterial switch, our transpositions and the Thoracic bings, most of these patients will have had their pulmonary arteries lecompted anterior to the aorta. The other thing to take into consideration is their coronaries are not in normal position. They're positioned anteriorly and usually are sitting just right behind that main pulmonary artery or straddling it on both sides. Something to take into consideration in terms of risk is these patients have circumferential suture lines at their sinotubular junction around their coronary ostia. So as congenital heart surgeons, we feel that they're quite often to some degree protected from propagation if they were to develop an isolated dissection. And also in terms of risk for rupture, their aortic root is really encased posterior to their main pulmonary artery with a lot of scars. So the concern, although they dilate, are they really at risk for rupture? And if you do encounter these patients, the best way to access their aortic root is by simply dividing their right pulmonary artery so you can rotate the lecompted pulmonary arteries off the aortic root to get access. I think truncus arteriosus patients, I think predominantly are going to still be referred to a congenital heart surgeon, but you may encounter these patients and they have a Pandora's box of coronary orientation. So their coronary ostia quite often have very abnormal locations. Many can be quite high above the sinotubular junction, juxtacommissural, or even intramural. Their truncal valves can have a wide degree of variability in terms of leaflet number as well as morphology. And all these patients are going to have an RV to PA conduit in place that needs to be considered. In terms of the dilated ascending and aortic root, it really varies by diagnosis in terms of the degree and the area affected. And as I stated before, all these patients baseline have significant dilation due to physiologic flow, both in utero as well as prior to repair. And the progression is variable depending on what their underlying diagnosis is. And so being aware of that in terms of how you counsel and monitor these patients is important. So here, looking at the dimensions of the ascending aorta and conotruncal heart defects, for most of these patients with tetralogy of flow and transposition, they have normal aortic valves at baseline that work normally. Interestingly enough, we tend to see increases in Z-scores more commonly in males versus females. All of these patients will have Z-scores well beyond the range of the normal population, so it's not uncommon to see an adult with a conotruncal defect with Z-scores of +5 or +6, which scares a lot of people when they see the numbers, but when you actually look at their rate of growth, it's different. And in terms of looking at these two panels, the upper one is demonstrating patients who have associated aortic regurgitation. So the blue line demonstrates that those who do have associated aortic regurgitation are going to have more progression of their aortic dilation, but even those without aortic regurgitation will see ongoing growth of their root. Uniquely, when you look at the patients with transposition of the great arteries with an intact ventricular septum in the female population, they actually have improvement in their Z-scores over time. Overall, there's now a lot of thought that these patients probably have just an intrinsic aortopathy that needs to be taken into consideration. Looking at guidelines in terms of how to manage these patients who have had prior coarctation repairs, really the predictors of whether they're going to dilate their ascending aorta is more dependent upon their age and presence of a bicuspid aortic valve, and less so in terms of residual coarctation or presence of hypertension. Interestingly, there's a very low reported risk of dissection in patients with conotruncal defects. Following arterial switch operation, despite the fact that we see continued neo-aortic growth throughout adulthood, again, the risk for dissection and rupture has been reported as quite low. And the majority of our truncus patients who have probably some of the most massively dilated aortas really have very few aortic-related complications. So when you look at the criteria, the upper part of this panel is all sorts of other indications for why you're going to intervene on the aortic, ascending aorta or aortic root, whereas you see these patients with congenital heart disease, there's really no consensus and really no guidance as to how these should be managed. But most importantly, I don't think it's fair to just apply the adult criteria to them. In terms of regurgitation, the systemic semilunar valve, again, except for those patients with truncus, tend to be, at baseline, a normal trileaflet valve with normal leaflet morphology and little regurgitation. However, these patients are at risk for ongoing progressive aortic root dilation, as well as neo-aortic root dilation. These patients also can have significant distortion of their valve leaflets associated with patching of VSDs with retraction of their leaflets, as well as development of subaortic stenosis. And again, with the truncal valves, the variable morphology of the truncal valve leaflets and number can contribute to the degree of insufficiency. It's important to understand what their baseline anatomy is, as well as their prior interventions to determine what's the best option for these patients. Most importantly, I always think, do they have an alternate semilunar valve that we can use? I think as congenital heart surgeons, we tend to lean into the Ross operation pretty quickly for these patients as the best alternative. Annulus size can be challenging, more so in those patients with Shone's complex or smallish left-sided heart structures with smaller left ventricular outflow tracts. But also the presence of prior subannular patch material needs to be considered in terms of your ability to harvest an autograft if you are considering a Ross. Here, looking at the growth of the neo-aortic root and prognosis, when you follow patients over a course of approximately 9 years, 10% of those patients will ultimately develop moderate or a greater root dilation, as well along with aortic regurgitation and require intervention. When you look at the color of these lines, the green lines represent those with TGA, intact ventricular septum, so the most straightforward of anatomy, blue being TGA with VSD, and the red being our Thoracic being patients. And you can see they all demonstrate dilation and growth of the aortic root and ascending aorta over time. But when you get to the far rightward panel, you see in terms of the composite risk of developing greater than moderate aortic regurgitation or requiring intervention, the double outlet right ventricle VSD or the Thoracic being population are the patients who are at greatest risk for progressing to aortic regurgitation. So even though you're seeing dilation in the other two categories, for whatever reason, their valves don't tend to leak over time, whereas the other population of Thoracic being are at the greatest risk. Again, looking at those patients who have had an arterial switch operation in terms of their neo-aortic root, again, the colors are similar. The green are, well, actually they're reversed. So you have the green are your Thoracic being, the red are your TGA VSD, and black is TGA with an intact ventricular septum. And again, they all demonstrate growth over time that's relatively similar. Next panel over is demonstrating the gender differences with men having a higher rate of dilation. But again, you see the worst outcomes in terms of progressive development of aortic regurgitation requiring intervention in the Thoracic being population. So what are your surgical options? We saw this slide yesterday, the Ross operation. It's been shown that that's the one operation that's going to put you back on your normal survival curve. This is definitely, if a patient has a pulmonary valve available, it's going to be our procedure of choice primarily for our patients. However, you really have to temper that judgment on what is the patient's age as well as their underlying comorbidities. And I think nobody really has come up with what is the age cutoff when you should say maybe we shouldn't do a Ross and we should go to a different valve. Also, you need to take into consideration surgeon experience and comfort in performing this procedure, and also take into consideration the risk of that neo-aortic root following a Ross procedure dilating over time and being able to support the annulus as well as support the root if needed. There's a lot of talk in our community about doing reverse Rosses. So those are patients who've had an arterial switch operation that have developed aortic regurgitation over time and moving their native initial aortic valve back over again. I think it's impossible to apply Ross data to a reverse Ross. This is a much more complex population. You're dealing with different anatomy of the valves. And so I think in general, we don't really feel that has the same survival benefit that you see with a traditional Ross. This was a great study that was done by Stephanie Fuller looking at various different bioprosthetic valves in the congenital population. And what's startling is when you look at young adults with congenital heart disease, the mortality in just 10 years following a bioprosthetic valve replacement is not insignificant. And when you look at age brackets, those patients that are less than 21 years of age get very little enjoyment out of a bioprosthetic valve. They fail quite early. And specifically, when you looked at valve types, the Sorin mitral flow was the one that had the earliest failure and really tends not to be used in this congenital population any longer. So when you see these data, it makes you wonder what is the best alternative for these patients. A Ross if they have a semilunar valve, doing a Yang or a Bo-Yang, doing a root enlargement. Many of these patients, when you look at their annuli, they were in the 21 to 23 range, so perhaps would they have had better outcomes if they'd had a larger valve placed initially? Or is this a patient population that really would benefit from a mechanical valve? We've dabbled a bit in the heart annuloplasty ring, so using this ring for congenital heart patients is a little bit more challenging. So this is specifically in the neo-aortic valve. So this is a valve that was once a pulmonary valve, so this ring was not designed specifically for this. The neo-aortic root doesn't have a true fibrous annulus. But in this population of 21 patients, we were able to have a successful repair in 20 of those patients. The follow-up was relatively short at 18 months, but no one had required further intervention on their valve. I think in many of these patients that they have normal tri-leaflet valves with good leaflet morphology, they're better candidates. I think when you start getting to patching and augmenting valve leaflets, you start getting into a slippery slope. Again, we looked at a larger population, including those with unicuspid and bicuspid valves, along with neo-aortic valve disease. Again, at short-term follow-up, we had good results with these patients. But I have to say, since publication, we've had some failures with ring dehiscences as well as leaflet restriction and perforation, so it's kind of tempered our enthusiasm. So I think you have to really balance the options. In a young woman with neo-aortic regurgitation that doesn't have a semilunar valve for a Ross procedure, in this type of patient, when you're balancing a mechanical valve versus an attempt at a repair, it may be logical in that type of patient. But here's an example of a patient with a bicuspid valve who had a beautiful repair with the heart ring, and 3 months later came back, and you can see the ring has slipped. It's pulled away from the annulus anteriorly. And this patient actually had subacute endocarditis as a result of their ring dehiscence and was ultimately able to have a successful Ross procedure. I'm not going to talk much about the Ozaki procedure. Bottom line is it's really not a valve repair, it's a valve replacement. You remove the leaflets, and as you can see, there's a very high reintervention rate early, so I think this is really an operation reserved for patients who need a short-term solution. It's not really a long-term answer. And then in terms of truncal valves, I don't think any of you are going to encounter these patients, as these tend to go back to congenital heart surgeons, but they often will have multiple valve leaflets with one being deficient. These patients actually have very repairable valves quite often by just removing a deficient leaflet and either tricuspidizing or bicuspidizing a valve. So what are some additional pearls? So in terms of prior aortic reconstruction, those patients who come to you that have had a coarct repair, interrupted arch, or hypoplastic arch repair, the patch material that we use for many of these arch reconstructions becomes heavily calcified over time. And so if you do start embarking on intervening on these patches at all, you quite often get yourself in a position where the entire patch is going to need to be removed and reconstructed. There also can be difficulties in terms of cross-clamping these aortas that become fully calcified. On occasion, this patch material can actually become aneurysmal rather than calcified and can cause compression of surrounding structures. And understanding that, especially patients who were done quite some time ago may have had a subclavian flap for their reconstruction and may not have a subclavian artery in terms of where you place your arterial lines. And specifically in the interrupted aortic arch population, the use of aortic advancement to bridge that gap that in their aorta can create significant challenges in terms of area foreshortened aorta in terms of your ability to cross-clamp that aorta, as well as causing compression of the left pulmonary artery or the left mainstem bronchus. So quite often in these patients, they benefit from getting an interposition graft in their ascending aorta to elongate their aorta again and create a larger space. In terms of intracardiac considerations, again, residual shunts is really important, especially on re-entry in terms of the risk of air embolism. Prior VSD patches and interventricular tunnels, these again can become highly calcified. They can impinge on the semilunar and atrioventricular valves and cause further valve dysfunction, as well as associated conduction abnormalities. Systemic venous baffling that we do for our senning procedures. So if you see an old patient that had a senning for their transposition, or now for our double switch patients, and these patients have a very large pulmonary venous atrium, which is going to be the atrium you encounter, and so they are not amenable to using a single stage cannula. You have to bicavally cannulate them. And in many of these patients, such as those who have had a senning, they've had their coronary sinus unroofed, or are single ventricle patients. So understand that those patients who are coming with aortic insufficiency, you don't have the ability to do retrograde cardioplegia for these patients, so having alternate plans available. So in conclusion, I think the adult congenital heart disease population is clearly aging and it's increasingly complex, and I think it's going to be increasingly encountered by our adult colleagues as these patients get into their 50s, 60s, and beyond. They pose unique anatomic considerations. It's important to realize that you can't just simply apply adult criteria to these patients in terms of determining what the best intervention and timing is for them. And really having an understanding of what their underlying operations and procedures are is really important, because really operating on these patients is a bit of an archaeologic adventure, and really understanding what you may encounter is very helpful. And I think this is a population that really benefits from having comprehensive teams involving both adult congenital cardiologists as well as adult cardiac surgeons and congenital heart surgeons to try to determine what's the best plan of action for each of these patients in terms of where they should be intervened upon, who should intervene upon them, and what should be done. So thank you very much. And another plug for Aortic Universe at the STS meeting in January 2025. I think this is going to be an outstanding session, and I hope we have many of you come and join us.
This presentation is open for discussion. Dr. Chen?
Jen, really enjoyed just a really outstanding, comprehensive review of all that. I wonder at your center, how do you handle the intraoperative conduct of the surgery? Is there a congenital and an adult cardiac surgeon scrubbed in? And I ask that because I've done several of these types of conal truncal root procedures, and and I didn't have a congenital surgeon. They were referred me from either a congenital cardiologist or adult congenital cardiologist, and we got through the surgery, but because of the altered geometry and relationship of the root and the PA, it wasn't completely intuitive, as if I was operating on normal anatomy. But I'm just curious as to what the thought is for the congenital world in your own practice with your team.
So we have a team that meets weekly to discuss these patients. So anybody that gets referred for surgery goes to the adult CHD group for review, and that again has representation from all the different areas, the adult cardiology, adult cardiac surgery, and pediatric cardiac surgery, so that we can have those conversations. I think the challenge is how do you flag them? Because sometimes the patient that comes in that doesn't seem like an obvious congenital heart disease patient can slip through the system. So for example, we had a patient who came in with a small VSD and AI, and was referred to an adult heart surgeon for primarily aortic insufficiency. It was completely missed on all the preoperative studies that she had a double chamber RV, VSD, AI, classic triad within congenital heart disease that would have been quickly thought of, but had a right heart cath, everything. Nobody picked up on the double chamber RV. And so then you get into the operating room in a situation where you wish you did have somebody else that had some expertise in that area, and it hasn't been planned out. So one of the things that we're working on is how do you make sure these patients get flagged as soon as they enter your system. I know what CHOP has, which they have a very well-oiled adult congenital heart program, is within Epic, they have a flag for these patients and it stays with them. So that once they enter, they immediately then go and they get a consult from the adult CHD team, so that you make sure that they get that multidisciplinary consideration.
Thank you.
Jen, I have a question for you, and it has to do with the conotruncal abnormalities. So the size of the ascending aorta in TET patients, the rest of the world in acquired heart disease are going by size, and that size gets smaller and smaller for recommending intervention. Although uncommon, it's not unheard of for old TETs to have dissections. A lot of discussion, no consensus about what the size is to intervene. So how big is too big?
I don't really think we know how big is too big, and I think this is where really getting a sense of rate of growth is important, making sure these patients are plugged in with close follow-up, and having some real way of measuring apples to apples. I think quite often these patients come in and they'll have, over the course of 8 years, a series of a couple of echoes and MRI to look at their RV and a CT scan, and you can't really equate any of the true measurements together, so it's really hard to track them. So I think consistent imaging of these patients for following them. The TET population, now that they're all followed in adulthood by MRI, is really helpful because you can also follow their ascending aorta. But I think the best thing to follow is the rate of growth, and also understanding that specifically for your male patients, they may be the ones that are at higher risk than your female patients.
And the similar question for patients who have had arterial switch operations. I know the incidence of aneurysmal degeneration, as you mentioned, is pretty significant. And although they may be prevented, they may be protected given the suture lines, but as the root dilates, they get more aortic regurgitation. And 30-year follow-up, that's pretty old for a congenital patient. That's pretty young for an adult patient. So when to intervene and valve-sparing routes and things for those kinds of patients' thoughts?
Well, I think that really is then dependent upon their valve pathology. So when they develop significant enough aortic regurgitation that you feel that they meet criteria for intervention, that's when they get referred. Again, the subtypes, a TGA, intact ventricular septum, they'll dilate a lot, but for whatever reason, their valves don't leak. So there's definitely a difference between the two groups. But it can be impressive when you look at some of these CT scans with these really big roots, and then they go to a small normal aorta and decide not to do anything. But once you have gone in and tried to do something on one of these patients, you realize that the risk associated with this is not the same as the risk that you would counsel another adult patient with a similar pathology. So again, that equation, I think, is where we have to rethink where we pull the trigger in terms of timing.
Thank you. Dr. Malasry?
Valve-sparing aortic root replacement after a switch?
I think they're actually quite good because, again, these patients tend to have at baseline a normal valve with normal leaflets, and it's really been primarily root dilation. That's the etiology. One caveat being if there has been some leaflet distortion associated with the VSD patch closure, which that is the one concern that you need to consider. But if you go in there and you have nice mobile leaflets, I think the chance for a valve sparing root is really quite good. You know, the technique you use has to be taken into consideration depending on when you get in there in terms of your ability to kind of externally get around that root. And so I think that quite often is the biggest challenge. And again, taking into consideration that mobilizing the coronaries can be very difficult because they're anterior position, they're usually pinned up against the back of the MPA. But actually, I think, you know, being able to repair these valves is quite often highly successful. But I think if you have to start considering using any leaflet extension material as part of a repair, I really temper my enthusiasm just because we've yet to come across any reliable material for tissue extension, for leaflet extension that's going to last.
Thank you very much.
Thank you.
Now we will move on to the